Hi everyone, I'm Karen Savage. I am a research manager for the 1917 clinic. I am introducing our speaker today for Penny Jester, who is on a much-needed vacation with her family. So today we're going to talk about a really interesting topic, therapeutic misconception. And we have our speaker today from the Cancer Center, Liz Busby, who has a lot of experience with trials. And I think cancer trials is a really good way to sort of introduce this topic. So I will let her start and we'll get going.
All right, thanks. So I'm Liz, and I know probably most of you here. This was a topic that I learned a lot about in researching to do these slides. So please join in. I love to get feedback and comment because it sure helps with this talk. This is something I've never presented on before, so it's kind of cool to research it. My title is Director of Oncology Clinical Trials at the Cancer Center, which we all know at UAB titles mean nothing. I basically just manage the clinical studies unit, which is kind of a smaller version of the CTO within the Cancer Center. So my background is in, I started out as an ICU nurse in the MICU. I was there for 8 years and then decided when you get married and have kids, you got to do something outpatient, right? So I went to the Cancer Center in 1995 and found a real niche for myself in doing clinical trials. In 2004, I did take a leap to the dark side and did some pharmaceutical things, but I've now made my way back to the Cancer Center in 2012. So, and I'm happy to be back. It's a never a dull moment. We always learn something new, and just like I said, in preparing for this, I learned a lot, and it really hits home when you start looking at this slide. So we'll get started. So what is therapeutic misconception? So therapeutic misconception was first described by Dr. Applebaum and his colleagues about and it's in the 1980s, and it made me feel so old. That wasn't that long ago, right? But in the 80s, and he refers to it's a tendency of participants in clinical trials to confuse the design and conduct of the trial with personalized medical care. In other words, they think they're getting treatment. So there are other definitions. I kind of looked around. There's lots of different ones. This one came from National Bioethics Advisory Committee. There's two different ones, and that's the whole thing. And when you're searching the literature, there's no standardized definition of really what therapeutic misconception is. One says it's a belief that the purpose of the clinical trial is to benefit the individual patient rather than to gather data for the purpose of contributing to scientific knowledge. Who's heard that one before? It's not a misconception to believe that participants probably will receive good clinical care during research, but it is a misconception to believe that the primary purpose of the clinical trial is treatment. And then this is more about what Dr. Applebaum said. He said, when research subject fails to appreciate the distinction between the imperatives of clinical research and of ordinary treatment, and therefore inaccurately attribute therapeutic intent to research procedures. All really saying the same thing in a different way. So why is it important at all? It really invalidates our consent process. If you think about it. When you're talking to the patient, you're clearly saying this is a research trial. And I think back to Jonathan Miller's presentation that he did a couple of months ago, saying that his friend that was in the triathlon and had some pulmonary issue was in a trial, and she remembered a little bit about what she knew, very little. Didn't see it as a trial. She saw it as an opportunity. So. Anyway, so the first principle of the Belmont Report is what? It's respect for persons. So persons have the right to decide for themselves whether to participate in research on the basis of the information that they receive. So we need to be real clear, in other words. What's the prevalence of therapeutic misconception? What would you think? Well, there was a study done. I found this at Human Radiation Experiments and National Commission, and they looked at 1,900 patients interviewed at 1,900 patients interviewed at 19 different medical centers. 67% responded that they had joined the trial to get better treatment. I hear that almost every day, and didn't readily make a distinction between the research and the medical treatment. So it's pretty prevalent, I would say. Empirical studies of clinical trials, predominantly early-stage cancer trials, which is us, indicate that subjects are often motivated to participate in research by expectation of direct medical benefit. And when asked, they blur that distinction. And I found this I thought this was really interesting. This was a pre-2011 statement found on the NIH website that says, so in other words, we contribute to therapeutic misconception. Participants in clinical trials can play a more active role in their own health care, gain access to new research treatments before they are widely available, and help others by contributing to medical research. So then this statement was found, it's still there actually. I think it was posted in 2014, but it's still on the website. And the blue is what's interesting, but also to possibly receive the newest treatment to have additional care and attention from clinical trial staff. True statement, but very encouraging. It still uses the word treatment that kind of, interchanges with clinical research. So this is on our website, the UAB Cancer Center's website. So you can see how we promote research. Clinical trials offer high-quality cancer care. If you're in a study and do not receive the new treatment being tested, you will receive the best standard of treatment. This may be good as or better than the new approach, so that's good. That's pretty honest. If a new treatment approach is proven to work and you're taking it, you may be among the first to benefit. I thought that was pretty cool. But very encouraging to the person reading that. Possible drawbacks. New treatments under study are not always better or even as good as standard care. So I thought that was a good qualifier, right? Taking part in a treatment study is up to you. It may be the only one of your treatment choices. Talk with your doctor. So together you can make the best choice for you. So again, I think we do make good statements. It's just that some of it is very encouraging. Not that we want to discourage. I guess that's not the point. The point is you just have to, when you're doing consent with these patients, you got to keep all this in mind of what's going through their mind. So what are contributing factors? Again, we talked about how on the website you can see encouraging information, but in context, research is done in the same setting as clinical care. We perform all of our outpatient clinical trials at Kirkland Clinic and a HEMOC clinic. We do a lot of the trials on the floor, or they're in the hospital, so that can kind of confuse patients. They're there to receive treatment, so therefore they get mixed messages. They're dual roles, so the researchers are often the ones that would take care of them anyway. So they're there to see them for treatment. They would have, even if they went on standard chemotherapy or standard care, it's the same physician who's also the researcher. And then sometimes our consent can be misleading or ambiguous. We hope not, but that can happen. And this just talks a little bit about how clinical research has evolved over years and how now even research is being done at community practitioners' offices. Used to, it was all done in academic centers, probably greater than 80% before 1990, and now you see a lot of research being done in the community. So patients are getting the same information from a lot of different places. So let's talk a little bit about misleading consent forms. This group, Henderson and Churchill took a look at some consent forms to see what might be some examples that would lead to therapeutic misconception. They looked at 321 consent forms, and this was on a gene transfer trial. Research and treatment were used interchangeably. And I could say if I was writing a consent, I might do the same thing because we all are from a clinical background. Surrogate endpoints, tumor shrinkage, immune response discussed, but not distinguished from the clinical endpoint, such as survival, or like in our phase 1, it's really to reach the maximum tolerated dose, or safety is the primary endpoint. Benefits to society and inclusion benefits not distinguished from possible medical benefits for participants. So, it just wasn't clear. So what kind of discussions can we have? Oncologists believe they said what patients believe they heard. I'm sure they say that. I have no doubt. But they did an analysis, and this article came from JCO in 2011. Findings, fundamental components in communication and information sharing are missing from the consent sessions with, they looked at just phase 1 trials. And then the discussion about prognosis and options for supportive care, palliative care were not always included in those discussions. I can see that too. They can lead the trials. So we just don't talk about that. What would we say about benefit in a clinical trial? So what might we say? May or may not benefit. Personal benefit cannot be guaranteed. Y'all tell me, what are some things that y'all think would be how we could better clarify what the consent form says? Any idea? These are just some that came off my head. There's no reference here. These are just me. Trial might not benefit you. You're unlikely to receive any lasting. I don't think I would say that. You are unlikely to receive lasting benefit. I think that's a little harsh. And participating may not improve your health or cure your cancer. So here are some other things that were discussed in the literature that are not exactly therapeutic misconception, but things, I guess, more or less contribute. They call it first cousins. That's what I found. Overestimating benefit. I've seen physicians do this many, many times. Or underestimating risk. Oh, you'll do fine. But we really don't know if they're going to do that. Misestimation of benefit and risk. So this is another study. 65 of 95 participants in a phase 1 oncology trial did not know they were enrolled in research.
Oh my gosh.
That's a big number in my opinion. But, I mean, you know, how many times I say, oh, I'll sign it, just give it to me. They don't want to read it. They just want to get what they think is the best treatment. 89 of the 95 participants in phase 1 trials estimated their chance of benefit as greater than 20% and their risk as little as 0. That came from a study. That was a real study looking at some phase 1 Yeah. And I can see how that can happen, especially in the elderly patients, or, you know, we get a lot of patients from rural areas that they just want to get treated. They're not worried about what that consent form says. And overestimating benefit. So it's not therapeutic misconception, but a near cousin, as they said. The subject knows it is research that has an unrealistic expectation to help. For example, investigator thinks the chances of participating benefit from a phase 1 trial are less than 2%, but the subject thinks it's 50%. So you're thinking very differently. So does this really jeopardize our consent? The difference between expectations and hopes, all hope. Helpful here, Dr. Jolly is forever referring to his new phase 1 group, or where they live at the hospital. So that's where that came from. And you know, it is giving our patients hope. Phase 1 trials are kind of the end of the road for oncology patients. So. Underestimating risk, not therapeutic misconception, but another near cousin. Example, the participant who is confident after an explanation of risk that he or she is immune to harms or tends to minimize this. No harm's going to come to me, my God, my grandfather, somebody is watching over me, my angel, you know, you've heard all those kinds of things. I'm sure blank wouldn't be offering this trial if it wasn't safe. I think I've heard that one before. I want to hear about the possible problems. It will only upset me. I know I've heard that one. So again, do these jeopardize the consent? Expectation versus hope. So these are some things, 5 dimensions of research that should be understood by trial participants. And that's part of our job is when we're discussing clinical trials with the patients, so we try to make these, at least these 5 points clear to the patient. We're looking for the trial is a scientific purpose. What is the primary objective of the trial? It may not be response. It may not be. It may just be a safety point. And we need to be honest about that. They may not hear it, but we need to say it. Study procedures. Procedures that are required by the trial may not always be required in standard of care. We're asking them to do a whole lot more than they would normally do. Some of these patients are really sick. I mean, we ask them to stand on their head sometimes. not literally, but we really do. They have to come in multiple times a week, multiple blood draws, and they usually do it with a smile. Uncertainty. There are many unknowns, and we need to let them know that. We don't know if the drug's going to work. We don't even know what the side effects might be, but we're going to do everything to take care of you. Adherence to the protocol. All these things we have to comply with everything that it says. The clinician as investigator, and that's almost the case always. Your doctor is your doctor, and it won't penalize you for being in a trial or getting out of that trial. They'll still be taking care of you. But they need to see it a little bit differently. He is the investigator. I don't think that's really done ever that I can think of. It's still the physician that's taking care of it. So what can the research staff do to lessen therapeutic misconception? Be aware that this exists with most clinical trial participants. The physician researcher should clearly communicate with the patient all their treatment options and clearly state that a clinical trial research is an option